I'm excited to share with you my pilot study on oncologist attitudes and beliefs towards crying with patients and how that relates to burnout. My disclosures, this project was funded by grants from CBSSM as well as the NIH Short-Term Biomedical Research Training Program. So I would like to start with a story. Um, As many of us do, we come to Michigan Medicine, pictured here, with big dreams. My dreams had to do with an interest in communication and how physicians engage authentically with their patients. I hadn't thought about crying specifically, but I had an experience on the wards that made me think about things a little differently. I was on my gyn-onc sub-I, and the service was a very heavy service at the time, which is to say that a lot of our patients were incredibly critically ill and were I think the whole team was sort of struggling to hold sort of the weight of that suffering. But after rounds, I did what I always did to recharge, which is I took advantage of the gift that I have as a medical student to spend more time with my patients. And I went to go spend some time with my patients. And I went to check in on a patient I've been caring for since the beginning, who was a mother of three. She had a big laugh. She loved astrology, and she had widely metastatic ovarian cancer. As we were talking, she told me that she knew she was dying and that she wasn't sure what to do. Our eyes met, we both started to tear up, and we spent the next several minutes, I think, just sort of holding space for this difficult realization that she was coming to and what that would mean for her and her family. Despite the hard conversation, I left it, although no longer dry-eyed, um, feeling a little lighter. And she later told me that she did too, which made me wonder if crying had anything to do with it. So, like the good medical student I was, I went to go look in the literature. Do oncologists cry with their patients? We don't really know. So there was a study in 1997 in Australia that looked at crying in hospitals. They surveyed doctors, nurses, and medical students and asked them about their experiences and attitudes with crying in the hospital. Um, they found that medical students cried the least often of that group, 31%, compared to 76% of nurses and 57% of doctors, but found that all of the providers shared sort of the main reason for crying being like identifying and bonding with patients and sort of feeling the weight of their suffering, especially with patients who were dying. Um, Several years later, Dr. Granick, who's a sociologist in Israel, who has done extensive research into emotional expression among oncologists, conducted a study called Oncologists' Negative Attitudes Towards Expressing Emotion Over Patient Death and Burnout. She and her colleague surveyed 177 oncologists from Israel and Canada and asked them about how they cope with patient death. She related this to burnout and found that negative attitudes towards perceiving emotion in grief was correlated with higher burnout scores. They only focused on one element of burnout, which is a concept called depersonalization, where you sort of feel outside of yourself and you cannot relate to yourself or to your patients in your like full authentic self. She also led teams that did some qualitative work using grounded theory to interview 20 oncologists in 3 different centers in Canada and ask them about physician culture and the culture of oncology and how that related to crying. So she found that oncologists felt that their culture saw crying or viewing emotion, expressing emotion as a sign of weakness. They felt that there was a stigma around death and dying, that oncology was especially focused on cure above all, and that there were also gendered dynamics where some some genders maybe had more freedom to express or willingness to express emotion. But still, all of this work was done in the context of death, dying, grief, and loss. And what I found myself thinking, looking at this, is that there is an opportunity to cry with patients that is not only after they've died. Um, Also, it's one thing to be curious about crying, and what's out there, but it's another thing to realize that potentially this curiosity has some stakes. And as Dr. Granick started to explore, there may be a relationship with burnout. So, burnout, the hot topic since 2020. I'm sure everybody in this room has filled out at least 100 surveys asking them about burnout, but I will quickly go over a couple of elements of burnout that are especially pertinent to medicine. So, the concern that there is a decreased ability to embrace complexity. So, this plays a role in how clinicians engage in the gray areas. They may fail to hear every viewpoint or engage in different perspectives. There's also a concern for diminished creativity with burnout. This is a sense of stagnation, feeling stuck, boredom, feeling emotionally or physically drained, and can lead to poor problem solving and an inability to tolerate chaos, which I know in my life would be a real challenge. Additionally, burnout correlates or includes insensitivity to emotional material in a sense to minimize. So you may have decreased emotional reserve, diminished capacity to feel, or decreased sensitivity to others' needs. And finally, there's an element of burnout around grandiosity versus inadequacy. And in medicine, there is a need for humility, self-awareness, and self-reflection that burnout makes much more difficult. Specifically for physicians, there's been extensive research done into burnout. And some of this research is very old. It's not all in oncology, but some downstream impacts of burnout include patient adherence. A study looking at primary care providers found that providers who were burned out, their patients were less likely to stick with their medication regimens. It leads to medical errors in and outside of the hospital. Altruism is impacted. Physicians feel less of a connection to their work and less purpose in what they do. Attrition. There is already a shortage of healthcare providers, and burnout sort of contributes to that churn. And finally, and perhaps like the most impactful to me, is that it erodes confidence in the patient-physician relationship. So, together, thinking about burnout and what we know about crying and emotion, this led our team to think about how these things go together. So, we made a hypothesis, a multi-pronged hypothesis. The first is that we thought that oncologists don't think that crying with patients is appropriate. Next, we don't think that they cry very often with their patients, because if you don't think it's appropriate, you're probably not doing it. And then as it relates to burnout, we hypothesize that oncologists who think that crying is more appropriate would be less burned out. And finally, oncologists who cry more frequently would also be less burned out. So how did we assess this? We created a survey. Our survey assessed behaviors and attitudes towards crying and included a burnout score. Our survey also included minimizers and maximizers. So, what are people's baseline emotions? Are you like my mom and you cry at every commercial with a puppy in it? Are you like me and you cry at the end of every novel? Or do you not cry in any situations? We also asked participants to respond to simple scenarios, asking how they would respond in if they were in the same situation or if they thought that what the oncologist was doing was appropriate. We included Dr. Granick's questionnaire assessing oncologists' perception of culture and emotional expression. And we included some sociodemographic questions. We surveyed physicians who practice oncology and who administer cytotoxic therapy. This became an important distinction because when you look at who treats people with cancer at Michigan, virtually every doctor may touch somebody who treats cancer, but we needed to narrow our pool for this pilot. So we identified 79 providers using the Rogel Cancer Center directory. We had an excellent response rate. 81% of providers responded out of this initial pool. That was 79%, so almost 80% of adult hem-onc providers and 100% of our gyn-onc providers. But because I am a future med peds doc and needed to make things more difficult and more complicated, I also wanted to include the pediatric hem-onc docs, and that decreased our response rate to 71%. I would still say it's pretty good, but we are still collecting responses. So if you know a peds hem-onc doc, please nudge them to fill out my survey. People who filled out our survey were pretty balanced. About 55% identified as female. Um, Half of the respondents were over the age of 45, half were under. And people who filled out the survey had been practicing sort of all throughout their careers. It was about a third, 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 less than 5, more than 20, and somewhere in between. So, how often do you cry with your patients? We asked. Some main takeaways here is that more than half of respondents cry at least once a year. No one cries once a week, and only 20% of providers said that they never cry with their patients. To get at how providers felt about whether or not crying was appropriate, we asked them, is it appropriate to cry with your patients? Almost half agree or strongly agree that it is appropriate and suggest that, they have a positive association, or positively perceive crying, or at least do not negatively perceive crying. Almost 40% weren't sure or ambivalent, and about 13% disagree or strongly disagree. So pardon the busy slide, but these 5 statements come from Dr. Granick's work and are supposed to assess how oncologists feel about crying in general, or she initially asked how they feel about emotional expression, but we asked how they feel about crying. And some big takeaways here is that I expected oncologists to not view this as particularly favorable, but in general, they disagreed with a lot of the negative statements here. So um, most disagreed that it's considered a weakness. Almost everyone strongly disagreed, and no one agreed that it goes against the aim of the practice of oncology, which is to cure patients. The only place that we saw maybe some evidence of some of the stigma that she had evaluated, or that she had found in her work, was around how acceptable it is in the workplace. And this, I think, has broader questions about the culture of medicine in general, not just oncology. So next, we wanted to learn about how attitudes about crying related to burnout. So we use the Maslow Burnout Inventory. Again, I suspect many of you have encountered this in your work. There is a specific index that can be used for healthcare providers, which is what we used. And there are 3 elements. The first is around emotional exhaustion. It's measured in 9 items, and this shows the extent to which providers are emotionally overextended or tired by their work. Higher scores mean more burnout. In our study, about 27% met the criteria for emotional exhaustion. And compared to a sort of an older study, but from 2015 in Europe, that showed that 51% of oncologists met the criteria for emotional exhaustion. The next index has to do with depersonalization. This is, again, the area that Dr. Granick had focused on in her work. This is 5 questions that get at a sense of unfeeling and impersonal response to the recipients of one's care. Again, higher scores indicate a higher degree of burnout. And in that old study in Europe, about 32% met criteria for depersonalization. In our study, 8% did. And finally, the third index has to do with personal achievement. This is 8 items. This looks at a sense of competence and sense of achievement, sense of accomplishment in your work, pride in your work. This is negatively coded, so lower scores indicate more burnout. And In the study in Europe, about 7% found that they lacked personal achievement. In our study, 20% did. But in order to be considered burned out by this measure, you need to have emotional exhaustion and one of the other two. And for our study, only two people met the criteria for full burnout. However, we did still run with the information that we had with each individual index to see if there was a relationship between frequency or attitudes towards crying and elements of the burnout score. We found that increased frequency of crying is correlated with higher personal achievement and therefore lower burnout. And we had a pretty significant result, a p-value equal to 0.01. Similarly, we found that the positive perception of crying is correlated with higher personal achievement and also lower burnout. Again, good significant findings, p equals 0.03. The last element we saw a trend. This wasn't statistically significant, but that the positive perception of crying did trend towards lower emotional exhaustion and decreased burnout. Um, Together, this does show a picture of potentially there being a relationship between crying and burnout. Um, in addition to our survey, we did have opportunities for participants to write in comments and had some qualitative information. So I'll just read this aloud, that the sheer volume of suffering that one sees as an oncologist wears on you over the years. It becomes necessary to steel oneself to this suffering. That does not mean that you do not care about people. It just means that you learn to not internalize their suffering in order to preserve your own mental health. And I thought that this quote got at something central that we were trying to get at in our pilot, which is that there's a relationship between the suffering of others and the suffering that we bring onto ourselves. And there's a number of ways to express that. There's a number of ways to express care. Crying might be one of those ways, but it also might not. And there are all kinds of steps that we take as individuals and as a medical community to sort of protect our hearts. Um, I did wonder if perhaps this aspect that this respondent was getting at might have to do with why people cry sometimes, but maybe not frequently. Could there be a relationship between how long you've been in practice and how often you cry? So, a quick discussion. Our results showed that a more positive perception of crying and a greater frequency of crying than we expected, certainly than I expected. And I wonder if some of this has to do with how old the literature was that informed our hypothesis. More than 10 years ago, did COVID make a difference? We saw that there is a relationship between crying and burnout and in areas previously unassessed. So, specifically looking at personal achievement and emotional exhaustion rather than just depersonalization. So, we know that there was already a relationship between emotional expression and depersonalization, but being able to establish the starts of potentially a relationship between crying and these other elements is new. Something that showed throughout the survey is the escape valve option, which is neither agree nor disagree. There was a lot of it. Some of that might have to do with just how people answer surveys, but maybe this is a reflection of uncertainty that people don't know how to feel about it, either because they don't know how others feel about it or they don't know for themselves. Or is it actually ambivalence that there is no way to feel about it? Crying is something that happens, and it's not good or bad. I'm excited to dig into the data to see if there's relationships with gender, time and training, age, or baseline emotional activity, because I suspect that that may have a role um, in how people feel about crying specifically with patients. And finally, I think that there's a question about how specific this phenomenon is to oncology. Um, I'm excited that there are providers in other fields, including critical care and primary care, who are interested in potentially adapting this survey to their environments. And at least for how burnout shows up in general in oncology, Oncology has decreased burnout compared to general internal medicine, with 38% in oncology to almost 50% in general medicine. So I wonder if this might look different in different populations. So a look at where this is headed. As you saw, it was a small study. There were only 79 providers that we identified, hoping to recruit those other 12 peds hemoncs, which is why that is my first next step. But it's only here at Michigan Medicine, and certainly the oncology community is much bigger than what we have here at Rogel. Um, We'd like to do a multivariate and subgroup analysis with some of the areas that I mentioned, and would also like to include patient surveys. It's one thing to ask an oncologist how much they cry and if they think it's appropriate, but what do patients think about it? And if an oncologist thinks that they're crying frequently with patients, do their patients think that the oncologist is crying frequently with them? Again, very interested in expanding this to other sites. I'm hoping that this pilot can lay the groundwork for potentially more funding to have multi-sites from around the country. Are there geographic differences? Are there differences in private practice versus community practice? And again, here in very small text, would love a K award down the line if there is any funding left from the government. So some key points. Um, our study is the first to inquire about oncologists' attitudes and behaviors towards crying with patients outside the specific context of grief and loss. Although burnout is heavily studied in the literature, crying is not, and its connection to burnout also is not. So this is novel, this is new, and I was pretty surprised that there wasn't anything out there. Um, Oncologists have more favorable attitudes towards crying and cry more frequently than we hypothesized. Positive attitude towards crying and crying more frequently is correlated with a higher sense of personal achievement and therefore a lower sense of burnout. And then I included this little cartoon over here, particularly for the boom compassion achieved. I think that there are implications for this work. The findings suggest that fostering open discussions among physicians and healthcare providers in all stages of training may play a role in how we humanize patient care and perhaps address burnout, which starts in medical school. I hope that it has implications for how we train and how we teach compassion. I just want to acknowledge my outstanding team, which includes Dr. Janice Fern, the head of the Ethics Fellowship, as well as Doctors Taylor, Veenstra, and Upal. And thank you. Here we see my models for excellent patient communication, George and Marv. Thank you.
Thanks, Hannah. All right, we'll change over to Anjola. Give us a minute while we change slides. Thanks, everyone.
All right. Does that look all right?
Looks good.
All right. Well, thank you for kicking us off, Hannah. And yeah, it's been really great to have a fellow MedPeds applicant do the fellowship with us. But yeah, for my presentation, it's titled Negotiating Life and Death in Organ Procurement, Normothermic Regional Perfusion, Biopolitics, and Our Collective Understanding of Death. And so my goal in this presentation is not so much to make arguments for or against normothermic regional perfusion, which is a procedure that I'll describe soon, but rather my goal is to describe the procedure, the ethical controversy behind it, and then highlight a few themes that I think are missing from conversations about NRP, as well as a few takeaways that I think can help us have more enriching discussion about it. All right, I have no disclosures. And then this is my outline. So I'll start by describing normothermic regional perfusion, or NRP, as I'll refer to it from here on out. Then I'll characterize the ethical controversy behind it, and then highlight three key themes as well as their corresponding takeaways. All right. So first, what is NRP? Just kind of broad strokes, and I'll get into it a little bit more. But Normothermic Regional Perfusion, or NRP, is a recent modification to organ donation after circulatory death, in which a machine recirculates blood to parts of the donor's body after death is declared. It improves the quality and increases the quantity of available organs. So for example, it's significantly increased the number of hearts that are available for transplant. However, it does appear to blur the lines between life and death and is ethically controversial. So for example, sometimes as circulation restarts, the donor's heart might start beating again. And to understand NRP, I think it's worth giving an overview of how death is defined. So medical legally, death can be defined in two ways. One is circulatory death, also sometimes called cardiopulmonary death. And this is the cessation of blood flow through the heart, cessation of blood flow through the body due to the heart and lung stopping function. And the other way is brain death, which is the irreversible and complete loss of function of the entire brain, even if circulation continues with artificial life support. And so correspondingly, there are two general protocols for organ procurement. One is donation after circulatory death, and the other is donation after brain death. And donation after circulatory death sometimes is just abbreviated DCD. One of the downsides of DCD is that organs are more susceptible to damage due to ischemia or lack of blood flow to the organs. And this is especially true for certain organs that are susceptible to ischemia, such as the heart. And so NRP is a modification of the DCD protocol that's meant to mitigate organ damage from ischemia and consequently increases the quality and quantity of organs donated. Since the advent of NRP, you can now do donations after circulatory death with versus without NRP. I'll briefly describe the DCD protocol without NRP. So first, the patient is declared dead by circulatory criteria. After that, there's a 5-minute hands-off period. And this is to ensure that no signs of life return, such as like a spontaneous heartbeat or a spontaneous breath. And then after that, organ procurement commences. Now with NRP, you still have those first two aspects. The patient is declared dead, and there's still the 5-minute hands-off period. But there's two key adaptations to the protocol. So first is that the carotid arteries, which supply blood to the brain, are clamped off. And after the arteries are clamped off, blood circulation is restarted through parts of the body, such as the chest cavity, the abdominal cavity, or both. And the clamping of the carotid arteries is done to ensure that blood does not go to the brain due to a theoretical concern that some brain function could return if blood flow is restored. And then after blood flow is restarted, organ procurement commences. And again, this is done because, or has been adopted because it increases the number and quality of organs available for transplant. And this is a more just visual representation. And so usually a machine such as ECMO is used to circulate blood back into the body, and the carotid arteries, which supply blood to the brain, are occluded before the circulation starts. I don't have the exact numbers, but a lot of major transplant centers across the country have started to adopt NRP over the past few years, including here at Michigan Medicine. Okay, so now, if you're not already familiar with NRP, you might imagine that this is ethically controversial to restart circulation after death has been declared. And so I will now characterize some of the ethical debates. And if we have time at the end, I can go through a little bit more of an exhaustive list of like arguments for and against it, but I'll just highlight two aspects of the debate. But first, it's just notable that it has sparked controversy both amongst clinicians and bioethicists. So one example of this is back in 2021, the American College of Physicians, which is the professional organization that sort of oversees internal medicine, they put out a statement against NRP due to ethical concerns. And then the American Society of Transplantation came out with a response to the American College of Physicians statement. So this just being one example of some of the debate about it. And then amongst the bioethics literature, there's also been quite a bit of conversation about it. And so this is the June 2024 issue of the American Journal of Bioethics, which for those that aren't familiar is sort of the premier bioethics journal. And so they had a special issue dedicated to NRP in 2024, which actually some faculty here at Michigan contributed to this issue. This issue featured lots of conversation for and against it, as well as pointing out various aspects of it. But aside from professional and scholarly circles, NRP has also made its way into the popular press with outlets like the New York Times and National Public Radio also having pieces about it. All right, so I'm just going to highlight two aspects of NRP. So one of the major sticking points about NRP is whether it violates the dead donor rule. And the dead donor rule is an ethical norm in organ transplantation, and it has two related but slightly distinct components. One of them is that vital organs must not be taken from patients until they die. And the second one is that patients must not be killed by the process of organ procurement. This has been a longstanding ethical norm and has also been very important in upholding public trust in organ transplantation. Opponents of NRP often argue that it violates one or both aspects of the dead donor rule. So donor patients were considered dead based off of circulatory criteria, but by restoring circulation, they no longer meet the standards of circulatory death. And now the patient might still be considered dead based off of brain death criteria, because by cutting off circulation to the brain, this would lead to brain death. But this understanding would suggest that the organ procurement process would be a proximal cause of death and thus a violation of the dead donor rule. Now, some people in favor of NRP believe that it does not violate the dead donor rule because the patient has always been declared deceased before NRP was started. So the dead donor rule is a key aspect of the controversy. And I think there's also important considerations with patient autonomy. So on one hand, there's an argument that NRP respects autonomy by allowing a person who desires to donate their organs to fulfill their wishes by increasing the likelihood of successful donation. However, this notion of patient autonomy in NRP remains contested, as some opponents note that there's not adequate informed consent. And so when a person signs up to be an organ donor, they're likely not aware about the possibility of NRP. Furthermore, organ procurement organizations have in the past explained NRP in an intentionally vague manner to donors' loved ones out of concerns that their loved ones will be less likely to proceed with organ donation if they understand the procedure clearly. And so I think this gets at a fundamental question in bioethics, which is how much information do patients and families need to be disclosed in order for consent to be informed consent? And so this is a big sticking point with NRP. So I'll now transition to highlighting three themes as well as corresponding takeaways that I think could be helpful in just enriching our conversation about NRP. And these three themes and takeaways were derived from my reading of a book called The Anticipatory Corpse, written in 2011. It was written by Dr. Jeff Bishop, who's a physician as well as a trained philosopher at St. Louis University. In this book, Bishop gives a rich historical analysis of the development of modern medicine and argues that the way we take care of dying patients reveals unspoken yet ubiquitous philosophical assumptions in medicine, and how these implicit assumptions shape our social understandings of death and the way we take care of dying patients. And while organ transplantation is not the main focus of his book, he does touch on it in the book, and I derive my themes and takeaways from his work. So the first theme that I'd like to highlight is that regulatory incentives to procure more organs may indirectly lead to ethically controversial innovations. So I think NRP is, at least in part, a downstream effect of regulatory entities providing incentives to increase the supply of organs. And I think this could be characterized as an example of biopolitics as described by the French intellectual historian Michel Foucault. Biopolitics generally refers to governmental and non-governmental entities producing policies and social norms that are aimed at regulating how bodies are managed in the population. And so organ procurement is an aspect of healthcare that is regulated by governmental and non-governmental entities, which produce policies and social norms. So for example, hospitals partner with organ procurement organizations, or OPOs, to do transplants. So here at Michigan Medicine, Gift of Life is our OPO that we transfer with, that we work with. So hospitals and organ procurement organizations follow guidelines set up by various regulatory bodies, such as the Centers for Medicare and Medicaid Services, as well as the Joint Commission. They regulate many aspects of health and medicine, one of which is the very relationship between hospitals and OPOs. And this regulation is good and necessary. There ought to be oversight over donation practices and ensuring that appropriate quality improvement methods are followed. But these regulatory agencies don't just regulate, they do also put pressure on stakeholders to procure more organs. And an example of this can be seen in the CMS guidelines for organ procurement organizations. And so this text is taken directly from the CMS website, and it says, quote, each organ procurement organization will be assigned a tier ranking based on its performance. So that would be tier 1, tier 2, and tier 3. Tier 2 organ procurement organizations will need to successfully compete for their donation service area or another donation service area in order to be recertified for another 4 years. All the donation service areas for tier 3 organ procurement organizations will be replaced by a better performing OPO. And so I imagine that the intentions of this competition is a good intention. It's meant to be a quality improvement measure to increase efficiency and lead to more organs. But it's natural that pressure to increase the number of organs will inevitably drive new strategies, and that includes strategies that may be ethically controversial. And so I think that the phenomenon of NRP is in part due to such regulatory and biopolitical pressure on stakeholders in organ procurement. And while we can't make a direct causation, I think it's fair to say that such pressure is at least one factor that has led to the adoption of NRP. So my first takeaway is that policies that govern organ procurement should take into account the indirect consequences of regulatory pressures and their ethical implications. And so this might look like really working closely with stakeholders, including ethicists, in the development of such policies. The second theme that I want to highlight is that organ procurement practices influence how we define death. And so this is just a reminder of the two different ways of defining death. And actually, the fact that we have these two different ways is deeply linked with organ procurement. So the concept of brain death emerged in around the mid-20th century. And prior to this, death was only really understood as circulatory death. However, medical innovations of the 20th century, such as the mechanical ventilator, made it such that we could keep the heart and lungs functioning in people with profound brain failure and permanent unconsciousness. people debated the moral status of these people who are in a state of what we would now today call brain death, but initially they were not categorically defined as dead. But a catalyzing event for the concept of brain death to emerge in our social imaginary was the Harvard Brain Death Committee of 1968. This committee's report is the first known use of the term brain death in print, and it was an important event leading up to the Uniform Declaration of Death Act in 1981. The connection between brain death and organ transplantation is clear in the committee's stated purposes, which in essence was to legalize organ procurement from people with irreversible coma by defining irreversible coma as a legitimate criterion for death. And so in order for organ procurement in people with complete and irreversible brain failure to be non-controversial, society's understanding of death needed to change at that time. Now, changes to our understanding of death are a normal thing, as death is both a biological reality and a social construction. And so as our societal knowledge and norms change, so do our ideas and attitudes around death. And I want to be clear that bringing this up is not meant to be a critique of the concept of brain death. I think brain death ought to be an appropriate criteria for medical and legal death, but rather I'm invoking this example to highlight the point that the inception of organ procurement practices are linked with how we define death. And so I think we tend to think of the relationship between our definition of death and our organ procurement practices as this way of where we have an immovable definition of death, and then that then informs our organ procurement practices. But I think history has shown us that it's a little bit more of a bidirectional relationship where our definitions of death do change over time. And one of the many influences is our organ procurement practices. And so I think NRP, sort of similar to the advent of brain death, it represents an example of how our habits and practices around death have the potential to change due to organ transplant practices. Restoring circulation to a person whose heart stopped beating used to unequivocally mean trying to keep them alive. But with NRP, we're seeing an attempt to modify our understanding of death to make it acceptable to restore circulation and not consider this act resuscitation. And so amidst this shift, we run into a bit of an odd paradox of initiating a life support machine in a person considered to be dead. And so my second takeaway is that debates about NRP should be aware of the potential for NRP to change our ideas and definitions of death. I think it would be a good exercise to ask ourselves, to what extent do we want to change our social norms about death to fit our medical practices? And conversely, to what extent do we want to change our medical practices to uphold certain social norms of death? There's no easy answer to that, but I think it's a good starting point for reflection. And now for my third theme, which is that death is a mysterious process, but our organ procurement practices depend on clear and unambiguous definitions of death. I think in the background of this entire conversation about NRP lies an essential question. And that question is, what does it mean for a person to die? In one sense, this question is intuitive, but in another sense, it's deeply mysterious. Death is the absence of life, but when we probe deeper into what this means, we find that it's difficult to fully define death, or life for that matter. There's a long-standing history of debate as to how we define death. And even when definitions of death are codified into law and entrenched in our professional and societal norms, that debate remains ongoing. I think there can be a tendency to think that if we just had more scientific and empirical knowledge, these controversies would dissipate. But this is not so, as death is both a biological and socially conditioned reality. The dying process complicates organ procurement. And I think this is represented in the debate about if NRP violates the dead donor rule. I think the reality that it's hard to come to a consensus is a symptom of the fact that death is indeed a mystery. And to be clear, we do need to employ straightforward definitions for practical reasons. We do need to have clear criteria to define when one is alive or dead so that we can, for instance, withdraw life-sustaining therapies, start funeral arrangements, execute a will, et cetera, et cetera. However, we should practice this in a state of humility and recognize that while we might draw a clear line between life and death, in reality, that line is blurred. And so that leads me to my last takeaway, which is that while we need concrete definitions of death for practical reasons, conversations about the ethical permissibility of NRP ought to acknowledge that death is a process. And so in summary, I just made this table putting together the themes and takeaways. So regarding the theme about the regulatory incentives that are placed on stakeholders, the major takeaways that policies that govern organ procurement should take into account the potential consequences of such regulatory pressures. The second theme being that organ procurement practices influence how we define death leads to my second takeaway of how debates about NRP should be aware of the potential for it to change our ideas and definitions of death. And the third theme of how death is a process leads to the takeaway that while we might need concrete definitions of death for practical reasons, we should at the very least acknowledge in the back of our minds that death is a process. All right, thank you for your time and attention, and I will hand it back to Janice for Q&A.
Thank you both to Hannah and Anjola for your presentations. I'm happy to take questions into the question and answer slot folks want. There is one question already for you, Hannah, regarding gender diversity in your sample to look at potential. Do you have enough there to look at potential gender differences among providers?
Yeah, I think it probably depends on what you mean by gender diversity. So none of the providers who answered our survey indicated identifying as a gender other than male or female. Other options listed were trans, non-binary, and an option to self-describe. But among those who identified male or female, it was about half and half. I think any kind of subgroup analysis is not necessarily powered with the number of people we've asked. So I think we're going to have to expand to multi-sites to look at any of those relationships. Thanks for the question.
Thanks, Hannah. Other questions? Okay. Before I get to other questions, I just want to highlight that in the chat is a link for the social work CEU credits. I don't want people to miss those. We'll also keep track of those who put your names in the chat for that. All right, another question for you, Hannah. Are there particular, how you're thinking about cross-cultural analysis or other ways to expand your work?
Dr. Baylor, I'm curious if you mean within the United States or more globally. Either way, it's very, very small right now, and I would love to expand it in any direction. So if it's a question that you're excited about, would love to talk about collaborating.
Great, thanks. I'm interested to just other places where either of you have been able to present this work or talk about this work, some of the sort of takeaways or feedback you've received from different groups. For Anjola, I know that this is part of your FASB work as well, was recently published. Congratulations on that. Just thinking about, other takeaways that feedback you've got, Anjola, and how this is in conversations, particularly in the FASB world, things that happen there.
It's really neat to work on this because I think this presentation is sort of the culmination of 3 different experiences that I've had. So in between 3rd and 4th year of med school, I did a master's degree in theology at Duke Divinity School. And that's where I read the Anticipatory Corpse by Jeff Bishop, and where I first sort of got the idea for those themes. And then this past summer, I spent 2 weeks doing the FASB fellowship, which for those that aren't familiar, it's a 2-week professional ethics program where people in various fields, medicine, law, journalists, so on and so forth, learn about the history of the Holocaust with particular attention to the role that each of our professions played in the Holocaust, and use that as like a starting point for reflecting more broadly on professional ethics. And we talked both about like historical ethical themes, but also we did discuss contemporary ethical controversies such as physician-assisted suicide as well as NRP. And that was the very first time that I really had a conversation with other people about NRP. And yeah, it was really rich and robust discussion, and definitely got me interested in this topic. And then lastly, obviously, this presentation was the culmination of my experience with CVSSM as well, and just spending a lot of time thinking about ethics.
On the NRP topic as well, Anjola, what's your awareness of how it's practiced in other parts of the world? And are there other sort of cultural norms or religious views that are not common to the US or US based for how folks approach NRP?
Yeah, good question. I don't know the specifics, but I know in some European countries, it was started to be adopted before the United States. And I actually want to say that in Spain, it was potentially adopted as early as the 90s, but I think mostly it was preceded in some European countries, maybe about 5 or 10 years earlier than the US.
Great. And then, so there's just a comment about given the concern for informed consent related to NRP, and just sort of how new it is. Do we know of any educational efforts that are taking place related to that specifically? And I don't know of any specific for NRP. I know there's ongoing efforts across the state and across all OPOs to provide ongoing education around organ donation in general. I don't know how specific it is to NRP.
Yeah, I don't know to the extent that there's sort of proactive education around NRP to potential donors. I do think that when it comes to the situations where it's discussed with families if they want to proceed with organ donation, I think my understanding is that OPOs have been providing more information about it in comparison to maybe like a few years ago when NRP was first sort of introduced. But yeah, on a broader level, I'm not sure. Yeah.
And Angela, got more questions for you as well. We're getting close to time though, so I apologize for folks who have entered questions that we're not going to be able to get to. But a thought of how do we think about xenotransplantation or use of non-human organs and how that might shift our conception of death in different ways, maybe back to circulatory definitions or more broadly. And your framework has interesting sort of things to think about in that space.
Yeah, I think, that's one of the, I think, benefits of sort of thinking about these broader, like sociocultural and biopolitical implications, because I think it allows us to engage more broadly than NRP, but just think more generally about the whole transplant apparatus as different innovations come, whether it be xenotransplantation. And yeah, on that question of xenotransplantation, yeah, I would say sort of the, and this is, I would say across the board, is just really getting public input being very important. In that American Journal of Bioethics issue, our very own Dr. Erica Andrist, she had written a piece about just the importance of getting public buy-in, and sort of the sense that there hasn't been enough sort of education to the general public about it. And so I think that's just a good general principle of really doing our due diligence of getting public input. So not just having these conversations in our professional and scholarly circles.
Thanks, Angela. I think that is a great note to end on. So thanks everyone for joining us. And please check out our events in the upcoming months. We'd love to have you back. All right. Have a good rest of the afternoon, everyone. Bye.